I know that Dr. Grubbs introduced himself, but I'm gonna do it again. Thank you for coming back, Dr. Grubbs. Dr. Grubbs received his medical degree from the Medical University of South Carolina. He completed his residency in internal medicine and pediatrics at the University of Alabama at Birmingham. He also completed a fellowship in adult and pediatric infectious diseases at the University of Alabama at Birmingham. He is now an assistant professor at the University of Kentucky, where he works as an infectious disease physician. He is certified with the American Board of Internal Medicine, Infectious Diseases, and the American Board of Pediatrics, Pediatric Infectious Diseases. Welcome back, Dr. Grubbs.
So to start with, we'll summarize where we're coming from. And so this just summarizes some of what I talked about last week. And please, if you have questions, especially this week where the main point is for question and answer, please bring them up as you see them or as you think about them, and I'm happy to answer. I'm fine with being interrupted and everything as well. As last week, I don't have any financial disclosures that are relevant to this presentation. So last week we talked about objectives for the presentation, being able to talk about some of the early history of HIV and hepatitis C and how that's been woven in with substance use disorder for both of those infections. And we talked about the epidemiologic trends for HIV and hepatitis C and substance use disorder and how those things have been related. And we wanted to help you guys be able to talk more broadly about the transmission and the pathogenesis and natural history and treatment and prevention of both HIV and hepatitis C. And so that's what I tried to touch on during the last week's presentation. And we'll sort of recap some of the high points of that here at the beginning. So I guess breaking it down by the two different infections for HIV, we talked about risk factors for HIV. And so this looks at new diagnoses of HIV in 2018, which is when some of our most recent data from the CDC is available. And it breaks it down into men and women. And when we look at men, the highest risk factor that comes in is men who have sex with men, but there's been an increasing trend with injection drug use being a risk factor, and there's a significant proportion of men with HIV where their primary risk factor is heterosexual contact. For women, the primary risk factor that we spoke about was heterosexual contact, but injection drug risk accounts for a larger proportion of women with new diagnoses of HIV. But there are fewer women with diagnoses. You see that the N up at the top of the charts for women is around 7,000 versus around 30,000 for men. So about less than a quarter as many women as men being diagnosed. But pertinent to substance use disorder, we talked about recent HIV outbreaks that have sort of highlighted the importance of substance use disorder, and particularly injection drug use and HIV transmission. And so the one that got a lot of national attention up front was one in Scott County, Indiana, and that was in 2014 and 2015. And it was initially identified when there were 17 cases of new diagnoses of HIV that were reported to the state health department in 2015 from the same county, where previously there had been few cases. And so at that time they started to scale up HIV testing and a syringe service program, but there were mixed messages that sort of were sent out from the government at that point in time, where they started this syringe service program, but at the same time upgraded syringe possession from a misdemeanor to a felony offense. And this had a major impact on public health overall, with about 215 cases having been attributed to this outbreak. And that includes with the main transmission routes being either through injection drug use or among those people who have sexual partners who inject drugs. And so we talked about how this isn't the only outbreak that's happened, that there have been other outbreaks that have happened in West Virginia and other parts of Kentucky, and even in more urban areas up in Massachusetts and in Washington State, and particularly in Washington State, where there are sort of more comprehensive public health systems in place. But there's been just a disconnect sometimes in how healthcare delivery and prevention programs have engaged patients with substance use disorder, particularly injection drug use. And there's been a need for better engagement to address this problem. And so in recognition of this, the CDC did an analysis in 2015 looking for counties with high vulnerability to HIV and hepatitis-C outbreaks. And you see that this map highlights where those counties are. And a lot of them are here in Kentucky and in surrounding states in the Appalachian region. And we had talked about some of the risks or the things that played into the vulnerability analysis was the availability of treatment for substance use disorder and the proportion of the population, substance use disorder and injection use, and also the availability of syringe service programs. And so apart from risk for incident HIV infections, apart from incident HIV infection, substance use disorder has an impact on HIV control among individuals who are living with HIV and also have substance use disorder. And it's associated with non-persistence in HIV treatment. And so to have successful HIV treatment requires people staying in care because it's a chronic infection for which we don't currently have an effective cure, but we do have effective treatment. And so for people who are able to stay in treatment for HIV and stay on medication, their life expectancy is fairly close to what it would be without HIV. But of course, if people are intermittently on treatment, that puts them at higher risk for morbidity and mortality and for developing, in some cases, resistance to HIV treatments so that those medications don't work for them anymore. And oftentimes that requires more complicated medication treatments. And so, apart from this non-persistence in HIV treatment, the substance use disorder is also associated with less consistent HIV virologic suppression. And it makes sense that with less consistent virologic suppression, there's a faster progression to AIDS, which is sort of the disease manifestation that we see of HIV among people who have uncontrolled viral loads and have had damage to their immune system. And this also translates into increased mortality, and that was something that was seen particularly among HIV-infected veterans in the VA system. Apart from just opioid use disorder, stimulant use disorder has also been associated with a 50% increase in progression to AIDS or death among HIV-infected men who are starting antiretroviral therapy. And again, just sort of reiterating that any type of illicit drug use, whether it be injection or not, has been associated with poor retention in HIV care. These are just some highlights, studies that highlight this from over time. We talked about just the development of treatments and medications for treating HIV and how that our repertoire of things that we have to treat HIV has expanded dramatically over time and really has still been expanding from when the first medications came out back in 1987 all the way until where we have multiple options for fixed dose combinations and single tablet regimens for people now. And we even have some combination treatments like Cabenuva listed here, which is rilpivirine, and cabotegravir, which can be given as a long-acting injectable medication that can act over 4 or even 8 weeks and can be used both for HIV treatment and for prevention of HIV infection prep.
We have one question in the chat. In regards to intermittent use of medication, is the resistance to medication solely for those with HIV or also for preventative PrEP?
Yeah, so that's a great question. So when we talk about resistance, it's more talking about people who have HIV infection and are on treatment as opposed to people who are on PrEP for prevention. I mentioned this before, but the virus mutates. It causes a lot of genetic mutations each time it makes a new copy of itself. Many of those genetic mutants don't have particular changes that make them more resistant to medications or not. Some of them don't really change much about the virus at all. Some of them actually end up in dead ends where the mutant virus isn't able to function properly to continue infecting. But if you have intermittent medication adherence, you can think about what the levels of the medication are in someone's system, and they sort of go up and down and up and down. And at those points when the medication concentrations are low in someone's body, you can think about it as the virus being able to replicate and still have some drug pressure. And so in those instances, that's where these drug-resistant mutants arise. And that's where resistance can become a problem. And the resistance it doesn't always just affect that single medication. It can affect multiple different medications that are related. And so it can make it so that future treatment options are more limited. We have, like I mentioned, more options now than we did in the past. And so we're better able to deal with it than we were in the past, but it still is an issue. For people who are on PrEP to prevent them from getting HIV, if they take their PrEP on and off, that can make it less effective. But there is data about how we can give people PrEP for just intermittent exposures, because many people, if you talk to them about how they have risk behaviors, the risk behaviors oftentimes don't come at sort of regular intervals. The risk behaviors might happen sort of in spurts. And for those patients, particularly for men who have sex with men, when that's their risk factor, it's possible for them to take intermittent PrEP. That hasn't been as well established for people whose risk factors are injection drug use, or for women whose risk factor is heterosexual sex. And some of that has to do with the time it takes to get good levels of the medication where they need to be. And so it takes longer to get good medication levels where they need to be for parenteral exposure or injection drug use, or for heterosexual sex for women than it does for men who have sex with men. And so that's just some sort of differences between the routes of exposure. And one thing that's important when someone's on PrEP, we typically don't give sort of the full treatment regimen that we would as if they had HIV infection. So it's only a partial treatment. It's only most of the time just 2 drugs instead of many times people being on 3 drugs or 2 different drugs for treatment. And so people who are on PrEP need to be regularly tested for HIV because it's possible to have breakthrough infections, whether that be because of incomplete adherence to the PrEP or just PrEP failure. And if someone were to become infected while they were on PrEP and they were just on partial treatment for a while, that's a risk for them having resistant virus that develops from that infection. So that's a good question. Any other questions about that? So let's see. There we go. So we talked this on that topic for HIV prevention. We talked about how condoms, they're highly effective for preventing sexual transmission of HIV if they're used effectively. And that means using them, or if they're used properly, and that means using them throughout the whole sex act and everything, and not just for part of sex. And we talked about how syringe service programs can be effective for HIV prevention for people who inject drugs. And medication for opioid use disorder is also effective in HIV incidence and preventing that. We talked about U equals U, which means undetectable viral load for someone with HIV, means that they're effectively untransmissible. And we talked about how that's mainly been shown for sexual transmission, and particularly for men who have sex with men, but also for heterosexual sex. Sort of the initial way that this was shown, however, was in the case of mother-to-child transmission of HIV. For women who are on effective treatment for HIV during their pregnancy, even before conception, and stay on it all the way through delivery, and then their children get antiviral prophylaxis for the first 4 weeks of their life, the risk of HIV transmission approaches zero. Even in large studies and cohort studies done in France, there were no transmissions that were seen out of thousands of babies that were born that fit into that category. If there's intermittent adherence to medication during pregnancy, there's a higher risk. And if you start treatment for HIV later during pregnancy, then there's a higher risk of transmission. Relevant to that, for breastfeeding in the United States, breastfeeding is not recommended for women who have HIV. It's not recommended. It's recommended they not breastfeed their infants because there is an association with breastfeeding and HIV transmission, and that has been described even among women who are on effective antiretroviral therapy and have suppressed viral loads. There have been instances of HIV transmission onward. And so that's one of the reasons why HIV infection is one of the few contraindications to breastfeeding in the United States. And we talked about for substance use disorder and injection drug use, if someone is on medication for their HIV and undetectable, the risk of them transmitting HIV through shared equipment is not really known, but they likely have a reduced risk. And some of the difficulty in determining that is just sort of the legal ramifications of trying to study something like that. And then we talked about pre-exposure prophylaxis. We talked about the different populations in whom this has been studied, mostly in, again, men have sex with men with the IPREX study, but in this BTS study down at the bottom, this was a study in Thailand among people who inject drugs, and it showed that PrEP is effective in that population as well. This table sort of reflects the fact that it's most effective among people who take the medications and have detectable levels of the medication in their blood. And so in those instances, it's upwards of 90% for preventing sexual transmission and upwards of 70% for those who have parenteral exposure or injection use exposure. But on the whole, for all people to whom the medication is prescribed, the risk reduction tends to be more in the range of 40 to 75%. And some of that's because of incomplete adherence. And so that summarizes a lot of what we talked about with the HIV. Now speaking more towards hepatitis C and its relations with substance use disorder and treatment. So this is data, again, from the CDC surveillance looking at acute hepatitis C. And again, we mentioned that most people who become infected with hepatitis C, they don't have an acute hepatitis. They tend not to have much of any symptoms, or if they do, they tend to be sort of symptoms that aren't bad enough to make them present to care. And so this would be an underestimate of the actual number of new infections of hepatitis C that are happening. But even though this is an underestimate, we still see trends where it's been increasing over time in this time frame from 2012 to 2019. And that doesn't seem to have slowed over the past 3 years either. And we talked about how these acute hepatitis C cases, their locations mirror where there have been problems with substance use disorder, particularly in Appalachia. We see Kentucky, West Virginia, Ohio, and Indiana, and some parts of Tennessee on that map that are dark, but then also other places where there's been increased incidences of substance use disorder and injection drug use, particularly Maine. And then we talked about how previously hepatitis C had been described as something that mainly happened in the baby boomer population as a overall public health phenomenon. But with the rise of these new cases, it's actually been in younger patients. And so there ends up being sort of what we would say a bimodal distribution. So two different sort of age cohorts where there's high rates of hepatitis C. And this is for chronic hepatitis C infection that we're talking about here. And so that has led for changes in the recommendations about who should be tested for hepatitis C. The CDC used to recommend that hepatitis C testing was only for patients who were in the baby boomer population or who reported risk factors for infection. Now the recommendation from the CDC and the U.S. Preventive Services Task Force is for all adults to be tested for hepatitis C. And that's in recognition of the fact that the age cohorts don't really, that they cross over, and that all adults are at risk. And so we talked about hepatitis C transmission, and we talked about the estimated risk for that depending on the type of transmission. With needle stick injuries or exposure to hepatitis C infected blood, resulting in about a 1.8% risk of hepatitis C infection. But mother to child transmission of hepatitis C for women who are actively infected with hepatitis C being around 5 to 6%. We talked about how studies looking at heterosexual transmission have shown minimal risk. And again, there was this cohort study of nearly 900 heterosexual couples over 10 years that showed no transmission. But we also recognize that there's a higher risk for transmission with anal sex, and particularly among men who have sex with men. And then this slide sort of highlights one of the big things that's important about hepatitis C treatment, and that's that it's effective. It is very effective and it's very simple, typically in terms of sort of the medical complexity of giving it. Most of the complexities that we have with hepatitis C treatment come from sort of problems with delivery as opposed to the medications themselves. When we look at sort of registries and everything in places where there's more universal healthcare systems like Taiwan, with different regimens that are pan-genotypic, the sulfosbuvir, velpatasvir, and the glucapavir, pabrentasvir being two of them, we see that the SVR12 rate or cure rate approaches 100%. When we look at sort of other cohorts that have been in more difficult to reach and treat populations, like this cohort in Scotland, where they had a scale up at this Tayside area where they were among people who inject drugs, we see that the actual cure rates were around 80% or so, but we know that that's mostly because a lot of the around 20% of people that didn't have cure, they weren't reachable for testing for cure. And so it's possible that they may have been or they may not have been, but it's just unknown. And so that takes some of this lack that we're seeing here, this almost 20% is just not knowing whether or not they were cured. And the same was seen in this Australian national cohort. And in the Australian national cohort, that's in a national cohort where treatment was being delivered by lots of different ways. That includes primary care providers treating hepatitis C, nurse-driven treatment for hepatitis C, treatment through syringe service programs and things like that. And the same was true with the English cohort. So with that much success, we talked about what are the particulars that we know about treatment success for hepatitis C among people who have substance use disorder. And one of the things that we know is that people who have active substance use disorder are less likely to be started on treatment, even though it's effective. We know that people who are on medication for opioid use disorder, they're more likely to be linked to hepatitis C care and treatment. And we know that even among patients who are on medication for opioid use disorder, there's still a significant proportion of patients who are receiving that care but aren't receiving care for their hepatitis C. And so that's a gap in how we deliver care. And it's something that's an important gap because hepatitis C over time causes health problems. And we have effective treatment for it. There are instances where there have been syringe service program-based clinics and MOUD clinic-based hepatitis C treatment that have lower barriers to care. And that's been shown to improve access and have good cure rates. And we know that treatment of hepatitis C in patients who are on medication for opioid use disorder is highly effective, again, greater than 90% cure rates. So what are barriers? why are people not started on treatment? Some of it has to do, we think when there have been surveys, has to do with fear of medical establishments and sort of competing basic needs. And also we talked about how hepatitis C, though a chronic infection that does cause problems over time, often doesn't cause lots of noticeable symptoms in the short term. And so people don't feel problems from it, and they don't see the need to seek out treatment, particularly treatment at that moment. And then there's a lack of experience of treating patients, often among prescribers of medication for opioid use disorder. Many of them have never treated hepatitis C, even though it's something that's relatively straightforward to do. And then in some clinics where providers see patients who inject drugs, there's poor access to things like venipuncture, and there's poor access to things like other means of assessing liver disease. And so that prevents treatment. In terms of prevention, we talked about how there's prevention of hepatitis C onward transmission among areas where there's good access to medication for opioid use disorder, and that there's even more prevention where there's good access for medications for opioid use disorder and there's good coverage for syringe service programs. And so that's sort of a brief recap. I used a fair amount of our time, but I think there's still plenty of time for question and answers. And I think we had some questions and stuff that had been sent in from this past week, and some questions that I think staff with Kentucky Open had made for us to sort of highlight some of the things that we were talking about. But please, particularly now, as we try to answer some of these questions, ask if you have further questions and things that we can help elaborate on. But this first one asks, what can non-medical professionals, and so that includes peer supports and counselors, working with folks with opioid use disorder, do to help them be diagnosed, referred, and engaged in care for hepatitis C and HIV? And I think one of the big things is just talking about it, talking about how people are at risk for hepatitis C and HIV. I think sometimes there's an underestimate of risk, or sometimes there's just a fear to acknowledge that risk among patients. I think the other thing that's important to talk about is why it matters. And so for hepatitis C, we have a cure. And so being diagnosed and being treated has the benefit of being able to cure someone from hepatitis C and have that not as a problem anymore for them. And that reduces the risk from them going on to have liver disease and other problems, things like diabetes and other sort of non-liver problems that can arise associated with hepatitis C. For HIV, I think it's important to emphasize also that there are good treatments that are available for HIV. And so if someone's diagnosed with HIV, and particularly if they're diagnosed early, that they can be started on treatment. And for those folks who are on treatment for HIV and stay on treatment, that their life expectancy can be near normal for someone else their age. And so those are important things for people to realize, and something that probably isn't sort of common general knowledge a lot of times. We still run into people who sort of don't realize that hepatitis C is something that's treatable and curable. And then we still run into people who don't always fully realize that HIV is something that we can treat and treat as a chronic medical problem, just like we treat diabetes and high blood pressure. It's something that for many patients that I see in clinic sort of becomes the background of their life. Just like their high blood pressure is sort of the background of their life. It's not something that they think about on a daily basis necessarily. And so those are things that I think could certainly be important to talk about, and just encouraging people to get linked with treatment and get linked with testing for hepatitis C and HIV. So I think awareness is one big thing. And then in terms of linkage, there are different clinics throughout the state. And so we have a clinic here in Lexington, there's clinics in Louisville, there's multiple other clinics throughout the state that are Ryan White clinics that have resources to help keep people in care. And so trying to link people to those resources once they're diagnosed It's important.
So we have a fair amount of peer support and care navigators, and so I was kind of wanting to do an informal poll / anecdotal evidence. How often do HIV and hepatitis C come up during your conversations with people with opioid use disorder or other substance use disorders? If someone would like to volunteer, or I will call on someone that I know.
I can say that I'm at BHG in New Vista Mar. Both of those provide buprenorphine as well as methadone treatments. And I feel like both of them also offer a pretty comprehensive care. So typically with me, it doesn't even get brought up very much. It's more the medical staff and things like that, and them getting linked to a primary care provider that way.
Well,
Thank you. Oh, go ahead.
okay, so at here at Madison County Detention Center, some of my participants that seek like treatment, I usually find out that they have either Hep C or whatever it may be through the application process when we're trying to refer them to a treatment facility. So that is how it comes up, and it comes up every time. I mean, every time that I'm referring them to a treatment facility, that's one of the questions they ask on the application process. So that's how I find out that information.
Are they testing at the jail where you're at?
I'm not saying that it's the participants that are telling the whoever's doing the application process, like intake at a treatment facility somewhere, like say a rehab somewhere. Before I could get them, they could go to the rehabilitation center, they have to fill it. They have to do an application process over the phone, since this is a jail. And that one of the questions that are asked are medical questions, like, do you have Hep C, HIV, this and that, or and then they either say yes or they say no. Which one? They say Hep C or HIV or whatever. But that's how I find out, through taking them through the application process.
And certainly for corrections involved individuals, there's a higher rate of both hepatitis C and HIV. Some of that has to do with sort of how our correction system treats substance use disorder, or doesn't treat, but I guess engages with that. But there have been programs with testing in jails and certainly in prisons where they found significant rates of HIV, and the proportion of patients living with HIV in the United States that goes through corrections in any given year is significant. And so that's a major venue there's an opportunity for testing for both HIV and hepatitis C. And there's been more push to do it in some places. Thank y'all for speaking up and everything. It's better to have not just me talking in something like this. So this question was for people with substance use disorder who are worried about their risk. What is the easiest way for them to get tested for HIV and hepatitis C? And so this gets at sort of the next practical step for what to do if someone is interested in getting tested. And if you do encourage someone to get tested, how can you direct them to that? And I would say that there are multiple ways to get tested. The health department is one way to certainly get tested. There's other AIDS service organizations that are in the community, so AVOL and everything. That's one way to get tested here. Many of the syringe service programs that exist in Kentucky have people who are there, particularly to do HIV testing. So there's an organization called CURP, which is the Kentucky AIDS Drug Assistance Program Reinvestment Program, and they fund employees at syringe service programs where that's their job, is to do HIV testing and linkage to care. And so that's one way to get tested. It is possible to get at-home tests for someone for HIV. They can get those over the internet. Sometimes they're available at drugstores and stuff like that. You can buy them to get tested. I guess some of the downsides of getting tested that way are that there's not always post-test counseling, but at least it's a way for someone to get tested. You certainly don't have to have symptoms to get tested. If you go to the health department and request the testing, they can do it there, and that can be free of charge. And so those are ways to get tested. If you ask at different ERs and physicians' offices, certainly at the primary care office, someone can get tested that kind of way. There are issues. This was when we got this question, one of the things that came to mind, this was a very recent published article that was talking about HIV and hepatitis-C testing and treatment availability among substance use disorder treatment facilities in the United States. And this includes facilities that are designated as opioid treatment programs. So that's places where methadone would be available, and those that don't have methadone available. And you can see that there's a significant, though there's improvement over time, there's still significant gaps. In 2020, overall, less than 50% of these programs were offering HIV testing. And we know that, this is a major risk factor for HIV. And, the numbers for hepatitis C testing weren't really that much better. Treatment availability at these programs is even lower. And so that has to do with sort of how comprehensive care delivery can be. And it is complicated to provide treatment based at MOUD clinics, but it has been done in some places. And so, like it says, there's about 16% of clinics that said that HIV treatment was available physically at their clinic, but there's still a gap there. For hepatitis C treatment, it really wasn't any better. And that's something, or wasn't much better. And that's something that certainly is remediable. The HIV treatment can be a bit more complex. Some of it just because it's a chronic kind of problem that goes on throughout time. But hepatitis C treatment has become simpler and simpler over time. And there's less and less need for medication or for monitoring while on treatment. And so that's something that we know we can do better in terms of providing low barrier testing and treatment. And so there are gaps, and that's something that's reported nationwide. And so this is just looking at other sites that sort of look at where we might be able to find HIV testing availability. And so again, all county health departments and other community-based organizations offer free and anonymous confidential testing. And then also there's this website that's called gettested.cdc.gov, and it lists places where you can get tested for HIV. And then this is more of a Kentucky specific page that talks about places where you can get tested.
Looks like we have a question in the chat and asking about the window periods for HIV and Hep C. So that would be, I guess, once you're potentially exposed.
Yeah, so the window periods from like exposure to the time where the test becomes positive, I guess, is what is being asked. And it varies depending on the type of test that we're talking about. I guess I'll talk about HIV first, and then I'll talk about hepatitis C. The answer is different for the two of those. For HIV, there are different types of tests. The point of care tests that a lot of times are done sort of at syringe service programs and at a lot of clinics. They're either second or third generation enzyme immunoassays. And so for those tests, there has to be enough time for there to be an antibody response that develops that can be detected by the test. And so that time frame is probably at the earliest around 3 to 4 weeks after infection. For the tests that are done in the ER here, for example, or that are blood tests that are sent out, those tests actually become positive a bit faster, and that's why they're done. They can become positive at around 2 weeks or so after exposure. There is just a viral load test, which can be done, and it becomes positive slightly earlier than that. And so the testing, there is a gap between when someone's exposed and when the test becomes positive for HIV. And if most people who develop HIV infection, they tend to have symptoms when they get it. Not everybody reports symptoms with acute infection, but most people do report symptoms, and those symptoms can be variable. They can be things from fever and sore throat with sort of swollen lymph nodes in the neck. Sometimes people report a lot of GI symptoms, so diarrhea, nausea, vomiting, belly pain. Sometimes people can report headaches, things like that. And if someone's got risk factors and reports those kinds of symptoms, then it's worthwhile testing for acute HIV, which would be a little bit different than a lot of these other tests, and could involve viral load testing, which becomes positive sooner. If someone's having symptoms and they're from HIV, then their viral load test will be positive. But then the natural history of HIV infection is, even if someone doesn't get treatment for HIV, those symptoms get better and they get back to feeling okay, but they still have the HIV infection. It's just sort of under the radar at that point, and it's causing damage, but not making them feel bad necessarily. For the hepatitis C, the way that we test typically is antibody-based test. There's a two-step testing recommendation from the CDC, and so it takes time. Antibodies are something that our bodies make in response to the infection, and so our bodies have to have time after they're first infected before the antibody becomes positive. And normally that involves at least around 4 weeks or so. Sometimes it can be a little bit earlier for some people, but normally around 4 weeks. Once the antibody becomes positive. Once the antibody test is positive, then it's supposed to reflex to a viral load test. And so that viral load test, some people are able to clear the hepatitis C infection on their own. And if they've done that, then the viral load test will be negative. The viral load test also becomes positive sooner than the antibody test because it's looking for the virus itself, but it's more complicated to do it. It's not available in the United States as a point of care test, and it involves having blood drawn to be sent for that test. And so, as mentioned before, that can be a barrier to some of that follow-up testing.
So I have kind of like a pointed question. So if someone has a known high risk exposure, like the day after, there's like a lag, right? So what would they do in that instance? So they do something, they're in a risky situation with someone with HIV or Hep C, and then the next day, obviously these tests that you would get at an SSP or a health department aren't going to help in that instance. What would the thing to do be?
Yeah, so none of the tests are going to be positive in that instance after the exposure, but before sort of any of those things become positive. So, and the answer is different for HIV versus hepatitis C. For HIV, if there's an exposure like that, we talked about pre-exposure prophylaxis. There's also something called post-exposure prophylaxis. And so in that instance, they've already been exposed. And so then we can give medications for HIV, and it would be sort of full treatment medications. So 3 medicines that they take for 4 weeks, and then they have follow-up testing afterwards. And we know that treatment with those medications for post-exposure prophylaxis decreases the risk of them getting HIV from that exposure. And some of that's been shown a lot of times from healthcare-related exposures to HIV. So needle sticks that happen in healthcare after someone's with contaminated needles after they've been used for someone with known HIV infection, then that's an indication to give post-exposure prophylaxis for HIV. Right now, there aren't recommendations for post-exposure prophylaxis for hepatitis C, but you of course should be tested. So there's not an indication to give medications in that instance when it's concerned about hepatitis C, but there is an indication to do the testing, and you want to do the testing most of the time. You would get it immediately just to make sure there's not prior hepatitis C exposure, and then you get it normally at around 6 weeks and then out at 6 months. Because with parenteral exposures and stuff like that, there's risk for other infections apart from just HIV and hepatitis C. There's risk for hepatitis B as well, and I didn't talk about that in this talk. Hepatitis B is less common than either HIV or hepatitis C, but it is something that is around. Kentucky is one of the states with the highest rates in the United States. And so, and it can be passed from needle stick exposures and also from sex. And so there is an indication for prophylaxis. If someone has a hepatitis B exposure or suspected hepatitis B exposure, they can get vaccine to help prevent it. And so we have vaccines that are very effective to help prevent hepatitis B infection. And if someone's had a known exposure, they can get vaccine, and they can also get antibody, which is like an infusion that someone gets to help prevent that. And anybody who's being seen who has risk factors for hepatitis B infections, so that includes anybody who has injection drug use as sort of a history, it's indicated that they get hepatitis B vaccine. That's something that all children get sort of as routine vaccination now. But for people who are adults, that recommendation didn't come out until many of them were sort of beyond the time when they would have gotten it in pediatric care. And so that's something that should be encouraged at anywhere where there's at syringe service programs and everything as well. And it is available at most health departments to be able to get that vaccine, but that's something that could be done better. And for people who have any type of substance use disorder, whether it be injection use or intranasal use or smoking, any of those things, they can be at higher risk for hepatitis A as well. And they're recommended to get hepatitis A vaccination. And so that's a series of 2 injections and stuff, or 2 shots. And it's recommended for all of those folks. So that's something that's important to get as well. Again, it's not it's off the topic of HIV and hepatitis B, but it's a common sort of exposure, and it's relevant to folks with substance use disorder.
Aaron,
it looks like,
oh, sorry. Can I ask a couple of questions?
certainly.
One is, so if someone thinks, if a client thinks that they may have had an HIV exposure, what's the time frame that they should try to seek post-exposure prophylaxis, and where would they go to get that?
So that's, again, like a really practical and excellent question. If they think that they've been exposed, really the time frame is within 3 days. So it's not a very long time frame. So if someone says that they were exposed last week, they should be tested, and they should have follow-up testing. And that's someone where if they've been exposed once like that, there's an indication certainly for PrEP, for ongoing exposure that they may have in the future, but that's not an indication for post-exposure prophylaxis. But if it's within those 3 days, then post-exposure prophylaxis is indicated. If they go to an ER, certainly if they go to the ER here at UK, they can start it that way. That's probably the most accessible way to do it. And that's sort of in recognition of the fact that, there's this 3-day time frame. And so if it happens on the weekend and stuff, it can be hard to tell someone to go to the health department when they're not open on the weekend and everything. If they go to the health department should be able to direct them to a place where they can get it. But again, like if there are barriers to getting there and everything, that can be a problem. So a lot of times the ER is the best place to go for that post-exposure prophylaxis.
And if someone has hepatitis C, and they're not sure if they've been vaccinated against hepatitis A or B, do you suggest that they go get vaccinated anyway? Are there harms in taking the vaccine if maybe you've already had it, you're not sure?
So there's not harms in taking the vaccine. If you have hepatitis B infection, or if you've had the vaccine in the past and you get vaccinated again, there's no harm in that. It doesn't cause harm to do it. There are tests that we can do to check and see if there's immunity, but that's just another barrier sometimes to actually getting the vaccine, and it can delay if we wait on getting those tests back, because they're not something that come back right away. So really, if there's an opportunity if someone's willing to get vaccinated and they have risk factors, they should just get vaccinated and not get the testing first, but just go ahead and get vaccinated for hepatitis A and B. And there is a combination vaccine product that includes both A and B. Both the A and B vaccines are more than one dose, so that means more than one shot. For hepatitis A, it's a 2-dose vaccine that are 6 months apart. If you just get hepatitis A vaccine alone. If you're getting the combination vaccine, then it's a 3-dose vaccine. And so it's one, and then a month later you get another one, and then at 6 months you get the last one. But even after one dose, there's significant protection. And so just getting that one dose in is meaningful. It's not as good as getting all of the doses, but it's better than nothing. And it can prevent someone from getting hepatitis B, A, and B, which can be very serious.
Thanks.
And it looks like, Laura, you'd also typed in a question, and you said if someone has cleared the infection, I guess you're talking about hepatitis C, and the viral load test is negative, could they become infected again and need treatment? And certainly yes. Whether they clear the infection on their own or whether they're treated and are cured from the hepatitis C. Hepatitis C isn't like measles or something like that, where once you've had it once, you tend to have immunity. It's something that you can get again and again, even after clearing it on your own or being treated. And we don't have a good vaccine for hepatitis C right now. There's a lot of people who are working on trying to figure that out, but we don't have one. And so if someone has ongoing risks for exposure, so ongoing substance use disorder, ongoing high-risk sexual activity, if they've been incarcerated, then that's a reason for them to get tested again. The frequency or how often we should be testing people, it's not completely worked out, but if someone has ongoing risk, they should probably be tested at least once a year, just to see if they're reinfected. And again, if they're retested, that antibody test, the first step test, is going to be positive because it's our body's response. And once our body sees something once, it remembers it. And so the antibody test stays positive. It never goes back to negative. But the viral load test is what you want to do. And so that involves a blood draw. It's not a point of care test. So it's a downside, but you need a blood draw. And it's something that is indicated probably at least once a year for people with ongoing risk exposures. Any other questions about the testing and post-exposure? Because the post-exposure prophylaxis, that's something that I didn't talk about last week, but obviously is very important. I'm sorry I didn't talk about that then, but it is something that's important, sometimes difficult to access, even for people with relatively low barriers to care. Sometimes post-exposure prophylaxis can be difficult to access. So being proactive, if someone tells you that, really encouraging them to go right away to get started on treatment is important. And it is something that oftentimes, if someone has any kind of insurance, it will cover it. Cost can be a barrier sometimes for people, but the only way that someone's going to be able to get it at all is if they sort of get in within those first 3 days to be seen, and that's the only opportunity that they have. And for HIV, it can be the difference between someone being infected with an infection that they're going to have for the rest of their life and preventing that.
Dr. Grubbs, can I ask a follow-up question to the post-exposure discussion?
Sure.
Sometimes it's difficult insurance companies may require a prior authorization to cover the medications that do have a significant cost, which can be a big barrier when you're trying to start it within a time frame. Do you know of any organizations that help with cost assistance for that type of scenario? I know with people who have experienced sexual assault, there's a fund for that, but I didn't know if outside of that, there was any type of funding that you are familiar with.
So yeah, certainly with sexual assault, there's good support for that. Most of the time when someone's in the ER, most ER's practices is to give people sort of like a 3 or 4 day supply and everything when they're leaving. And so that's obviously not enough for the full 4-week course, and cost is a barrier. The manufacturer sometimes has some resources that can help with it, but those take time to access as well. It's a difficult problem. I don't know necessarily of particular resources always to help with this, but I think getting someone in care to even be able to sort of wrestle with that is the first step, and then to try to explore it more once you get there. I'm sorry, I don't have a great answer for that.
That's okay. I didn't think about it. I just was going to see if you might off the top of your head. Thank you.
No, it's a great question. Anything else? Because those are really pertinent. I mean, a lot of times, as coaches and everything, you guys might be some of the first people to encounter people who tell you about these things, and so that's really important. Yeah. So this is saying that Gilead has assistance for PrEP, and they certainly do. But I'm not sure about post-exposure prophylaxis or PEP. And so I agree with that. I don't know that they do. Please interrupt me if there's other ones that come up, but I'll move on to some of these other questions. Let's see. So what is best practice for MOUD providers to screen and connect patients to treatment of hepatitis C? And so, and then there's a few other things that are sort of related to this. And so we talked about how it's surprising to hear how few physicians that prescribe medication for opioid use disorder also treat hepatitis C, because these are co-occurring disorders. And I think some of it just has to do with we have silos in medical care where people tend to specialize in one thing or the other. And so there's not as much sort of, those are barriers to comprehensive care. But like we said, there are different programs where people can get experience and can get sort of mentoring experience in how to treat hepatitis C. And so I think those are good things to access. There are some barriers historically for providers who are prescribing MUD to treat hepatitis C. Some of those have to do with there used to be sort of insurance requirements that someone see either an infectious disease or GI physician to make those prescriptions. Since that time, so over time, most of those restrictions have gone away. And so that's not required by most payers any longer. There also used to be a requirement for sort of establishing the chronicity of hepatitis C before it could be treated. And so that means, basically that meant that people, once they were diagnosed with hepatitis C, because some people clear it, the payers sort of said, well, we don't want to pay for treatment if someone's going to clear it on their own. So you need to prove that it's chronic and that it's not going to go away without treatment. And so they required that there was a second test out at 6 months. And so you can imagine how many people would fall out of care in that 6 month time period and not get treated. And that restriction's basically gone now. And so a lot of those barriers have gone away, but a lot of times it's not advertised that those barriers are gone. And so it could be that providers tried to do this in the past and they ran into those roadblocks. And so because they ran into those roadblocks in the past, they might not try again now or in the future. But I will say that a lot of those roadblocks have gone away and treatment is more accessible now. And then the question about HIV, and I would say that HIV treatment is a bit more complicated than hepatitis C treatment, partly just because of the chronicity of HIV and the fact that it's not cured with treatment, but it's a long-term ongoing thing. Certainly, I think that there are many primary care providers who do treat HIV and do it effectively and well. And I don't think it's something that's out of the reach of primary care providers. I think that it can be intimidating because there's so many medications. But if someone's interested in doing that for their patients and everything, there are resources in the community to help with that. This next slide sort of highlights some of the resources for hepatitis C and for HIV. For the HIV, I would sort of highlight particularly this last one, this AIDS ETC. So it stands for AIDS Education and Training Center, and it talks about training opportunities, and that includes for HIV and for hepatitis C. And that's lectures, but it also involves like mentorship type programs and things like that to help with even more if someone really wants to get involved and do something beyond just sort of testing and beyond prescribing PrEP or something like that, even with prescribing PrEP, the AATC has programs that help engage clinics to sort of help improve their testing and their awareness, and help improve sort of the availability of PrEP in those clinics and hepatitis C clinics. There's also a program called KHAMP, which is really more organized to the University of Louisville, but also here. And it is a program to improve the availability of hepatitis C treatment. And so it is a mentorship program that educates primary care providers on how to successfully treat hepatitis C and evaluate patients for hepatitis C. And so that's a more structured program that goes over the course of a year. It's been successful in helping to enable providers to treat hepatitis C and helping people get hepatitis C treatment. There's also other websites, so hcvguidelines.org, that's sort of the national guidelines about how we test, manage, and treat hepatitis C. And it's really a pretty easy to navigate website. It has menus and stuff that are pretty simple to follow. And it's updated regularly. And it emphasizes sort of accessible guidelines and the ease of treatment, with the idea of trying to help more people be treated. There's also this educational website that's a national curriculum for hepatitis C. And this is out of the University of Washington. And similarly, apart from hepatitis C, they also have a national curriculum for HIV that is available. It's all web-based, that goes through sort of what the guidelines say in slide format and helps to sort of educate electronically. And so these are resources, and certainly if you run into providers that are interested in knowing more about how to treat hepatitis C or HIV, I'd ask that John would make my email available. I'm happy to try to help with that. That's something that I feel like is really important. And so I want to be a resource for that. If you have providers that you know that want that, let me know and I'm happy to help.
So I think we have time for one more question. And the question that I think in my head kind of sticks out is, like, we have these HIV and we have Hep C, and there's so many actionable steps at each stage in the process that can help get someone access to care and that they're treatable. But I think we had a question that, like, what are the ramifications of untreated Hep C? Like, what happens? Because I think everyone kind of has an idea of what happens if you don't treat HIV and what it becomes and what can happen. But what happens if you don't treat Hep C? What are those ramifications?
Yeah, and so if we talk about sort of the natural history, or what happens if someone has hepatitis C, like we said, most of the time it's not something that's causing people symptoms right up front. And so most people, unless they're screened for it, unless they're tested just because of risk factors or because they're a person that sort of falls into the categories for screening by CDC or USPSTF recommendations, then they're not going to necessarily seek testing. But it's silently causing damage to the liver over time. And so we know that somewhere between 1 in 10 and 1 in 5 people who have hepatitis C that's chronic, if they don't get treated, that over time they develop cirrhosis. And so that's sort of hardening or a stiffening of the liver. And the liver is one of the organs in our body that makes a lot of the proteins and stuff that we use for in our blood, that makes clotting proteins and things like that. And it also acts as a filter. And so it's sort of like the filter gets clogged up, and it can cause swelling in someone's belly, swelling in their legs if they have cirrhosis. They're also at increased risk for getting liver cancer over time. And so that's something that if we treat the hepatitis C early before it causes cirrhosis, then the risk for liver cancer related to that is very low. But if we wait and treat after someone has cirrhosis already, the treatment still decreases their risk for liver cancer, but it's still high enough that we should continue to screen for it even after they're successfully treated. And apart from just the liver disease, which is the major concern, having hepatitis C that's untreated increases the risk for other types of cancer. So for things like lymphoma, particularly, there's increased risk for that. Also increases the risk for kidney disease and some types of arthritis and skin problems and everything as well. So things like, so those are all sort of consequences that can happen from untreated hepatitis C. It's not something that happens sort of inevitably in someone who has hepatitis C, but it happens in a large proportion of people. And so the treatment is relatively short. It's only 8 to 12 weeks. It has relatively minimal side effects. And so that's a benefit of it. And it's very effective. And so it's something that sometimes gets put off, but it is important to seize the moment that we have to treat people when we can.
Aaron, what if somebody with hepatitis C gets pregnant? What are the risks of transmitting to the baby, and when is the best time to treat in that situation?
Yeah, so right now the medications that we have for treating hepatitis C aren't approved during pregnancy. There is an ongoing trial looking at treatment during pregnancy, but that's not something that we really know the results of yet. And so right now, certainly there's a recommendation that all pregnant women be tested for hepatitis C, and that's sort of starting to permeate out to where it's actually happening. It's law in Kentucky for all pregnant women to be tested for hepatitis C. And that's been the case in Kentucky for a while, but even more broadly, it's recommended now. The risk of a woman passing on the hepatitis C to her baby, if she has active infection, is probably around 5-6%. And so that's about 1 in 20 children who are born to women that have active hepatitis C get that infection at the time of birth. And if they do, so any child that's born to a woman who has active hepatitis C should be tested for hepatitis C on follow-up. And treatment is available for children as well. It's not available until they get to around 3 years old. But for women, most of the time we would not treat during pregnancy, but as soon as they deliver and have the baby, we can start treatment. And that's important because there are many women who will go on to be pregnant more than once. And so if we're able to treat between pregnancies, that avoids sort of another child from being exposed at the time of birth.